I am pleased to be with you this evening or today, wherever you are in the world listening to me. And I'm happy to discuss one of my favorite topics and one in which I have been involved with much research over the years. And of course, that topic is the one we are discussing this evening, which are mouth rinses, lotions, or potions. Now, before we start, I'd like to discuss with you what my positions are in terms of research I'm doing and have done and consulting I'm doing or have done in the past year. Being the director of the Center for Clinical Dental Studies at Buffalo, I'm involved with many different companies, as you can see, and the more recent ones are shown here, and they include Colgate, Curazone, Johnson & Johnson, Church & Dwight, St. Renatus, U First, and Sunstar. This is a picture from the Harry Potter studio in London, and of course here Harry Potter's making up all his various lotions that are made up in the magical kingdom in which he lives. But what I would like to discuss with you today is what is the evidence behind the various products that we have out there that we can and should recommend to our patients. And if we don't have the evidence, then we don't recommend. Now the question is, to rinse or not to rinse? And that really is our basic question. And so let's look at this question for a few minutes. Well, basically, what's the rationale behind the use of mouth rinses? Well, we know this. Teeth make up only 25% of the oral cavity, and mouth rinses, of course, reach many of these surfaces. Now, as a liquid, mouth rinses carry the antimicrobial agents not just to the teeth, but of course to all areas of the mouth. Lastly, plaque biofilm cannot be managed by toothbrushing and flossing alone, and I will share with you some data which will make that point as we talk today in our presentation. As a matter of fact, in terms of tooth surfaces where plaque biofilm was located, 25% of those surfaces are the tooth surfaces themselves, but we have to remember there's the rest of the mouth, and 75% of those surfaces are located on the tongue, the oral mucosa, the oral pharynx, and this is where the other biofilm forms, and these serve as reservoirs even though we can get them off the teeth. However, the nice thing about mouth rinses is that they will reach not only the tooth surfaces, but also other areas of the oral mucosa. Now, brushing and interdental cleaning are not always enough. Now, we know this, that a little more than 50% of adults have gingivitis, across the world. Now, in terms of how people maintain their oral hygiene and control biofilm, only 2 to 10% of the population actually floss once a day or interdentally clean once a day. Depends on which procedure in which part of the world we're talking about. In the U.S., the numbers we're showing here for the U.S. say that only 2 to 10% of the population floss once a day, following the American Dental Association recommended procedures to remove plaque from between the teeth. Even with regular cleaning, areas may be missed, and if we look at this picture with me, I'll show you. This patient is a patient from a study we did, and we taught the patients how to brush and how to floss. And we then gave them a videotape to take home as to how to do this, brought them back a week later, and said, let us score your mouth now and see how good a job you are doing with the directions we gave you. And very surprisingly, these are the flossers, and you can see this patient did well on this side, but not too well here. They did pretty good here, missed a spot here, did fine here, did fine here. And up here, again, we see another area where they missed. So these are the proximal areas that are sometimes what we refer to as the hard-to-reach areas, as are the subgingival areas as well. And these are the areas where the mouth rinse, especially the interproximal areas, these are the areas where the mouth rinse can help these patients to remove the plaque, which is biofilm, plaque biofilm, which has been missed by their mechanical methods. As we see here, it'll help here, here, a number of areas. All of this will lead to better oral health for our patients. Now, when you think of mouth rinses, think about why do we have them and why am I going to use them? Why am I going to recommend them? Well, one reason we recommend them is that to treat a disease process. That disease may be caries, where we'll use fluoride, or it can be gingivitis, where we'll use chlorhexidine, essential oils, other products like that. Or it could be candidiasis, where we'll use anti-candida agents to treat lesions in the mouth. Now, especially today with the xerostomia being on the increase, due to the fact that our population is growing older, and there are more and more people taking medications that cause xerostomia, xerostomia leads to candidiasis. So now I want you to begin to watch for your patients, not just for caries, not just for gingivitis, but also for candidiasis. Now, the other category is using these as preventive measures. In other words, not to treat, but sort of to prevent as part of our regular oral hygiene regimen. So we can think of these products then as anti-plaque, anti-gingivitis, and anti-candida agents for some types of products. Then thirdly, some mouth rinses are really purely cosmetic, and there they help for brush freshening, they help for a whitening of teeth, procedures like that. So if you think of the categories of the mouth rinse, that helps you to decide, why does my patient need it and for what condition. Now let's take a look at the biofilm on teeth. In this picture I'm showing you here, tooth surface was cleaned, and this is now 1 hour after the cleaning. Plaque bacteria are already starting to accumulate. This is now 2 hours after the cleaning. Take a look, we now see more and more bacteria coming together. Now, at 24 hours, we have a very, very strong biofilm which has been formed. And now this biofilm, here we show magnification of it, this biofilm, these bacteria are working with each other to protect each other from any assault on them, and they're also producing toxic products that can cause inflammation in our gingival tissue, and this inflammation, of course, can lead to gingivitis, and if it's implants we're talking about, peri-implant mucositis, and from there we go to periodontitis and peri-implantitis. So let's take a little closer look now at biofilm. And here we have a video to show you, taken through our microscope, of course. As you look at this video with me, notice what's happening. This is biofilm on our teeth. It's not something that's just static. As you can see in these pictures, bacteria are moving. There's a fluid that carries them along through the biofilm. There are different centers of populations in the biofilm. See this? And notice how the bacteria approach the center of population. Some of them attach, some of them detach. They continue circling through this biofilm, going through all the various areas, creating the colony that is going to cause the inflammation that we would like to prevent. The colonies that will lead to the gingivitis and will lead to the peri-implant mucositis. Now, the significance of biofilm, or its importance, is this. First of all, bacteria and biofilm are adherent to surfaces. Now, this is important. This is in contrast to free-floating, or what we sometimes refer to as planktonic bacteria. Now, the free-floating bacteria usually are grown in a test tube. They're usually grown in 1 or 2 mixtures of bacteria, and these bacteria are not the same as bacteria in biofilm. In order to know what effect an agent has on biofilm and other bacteria in the biofilm, we have to use studies in which the initial data is based on the effect on biofilm and not just bacteria in a test tube. Some companies will present data to you and say, we have this great test tube study showing that our product kills bacteria A in test tube A and bacteria B in test tube B, bacteria C in test tube C, but that means nothing. That just tells you that now this product should be tested in a true biofilm system, including in vitro and in vivo studies, to see if the product really works, not just on bacteria in a test tube free-floating, but rather bacteria living together in this biofilm population. Now we know this, the bacteria in the biofilm are more resistant to antimicrobial agents than planktonic bacteria. As a matter of fact, the biofilm forms a shield, and this shield impedes access of agents. As a matter of fact, one of the things you'd like to know about a mouth rinse is that if it's working, does it work and penetrate into that biofilm that we have on the tooth surface? Secondly, bacteria may undergo phenotypic changes within the biofilm, and that can increase resistance. Now, luckily, with the strong mouth rinses we have in the market today, such as the essential oils and chlorhexidine, the resistance has not been significantly demonstrated with either of these very strong mouth rinse products. And now here's the important thing. Mouth rinses that are effective against the planktonic or free-floating bacteria may not be effective against bacteria and biofilm, as I said a few minutes ago. The bacteria, these are different kinds of bacteria, and they react differently to chemical agents, and so we have to look at the biofilm bacteria and agents in that biofilm to see what the effect of a product we are considering to recommend for our patient is. Here's the key principle with biofilms. Being attached rather than suspended makes a world of difference. I'll repeat that. Being attached rather than suspended makes a world of difference. Attached is to survive. Attached is to survive, and that's how these biofilms survive on the tooth surfaces of our patients. Now, what role does mouthwash play in better plaque control? Well, let's take a look at the data. Now, better plaque control, it means not just using the mouthwash products, but also using mechanical agents with them. Here we see devices to help the patients clean in those areas between the teeth, which we know are difficult for many of our patients. Proxy brushes are of value if we have adequate diastema. Proxy brushes are of high value around implants. And then we have the soft picks, which are of value around implants and also around teeth. Now, what these products do is they disrupt, just like a toothbrush, they help disrupt the biofilm in the teeth, increasing the access to the biofilm by the chemical agents we are using. Now, this point is important because we have to make our patients understand that if they just do brushing and mechanical methods, they're going to miss some areas. But we have to use those methods, but if we add chemical agents to them, they enhance the mechanical methods that the patients are using. Now here's using the proxy brush, and we're using it around implants, and by doing this we end up with implant surfaces which, as you can see here, are very, very clean, and this patient's been doing this for a week now. Tissue is very healthy, and this is how we like our implant patients to look, with these very, very clean surfaces and this very healthy looking gingiva. Now, here's a point I'd like to make. If you look at the proxy brush, the bristles are attached to the core. Where this attachment occurs, if the patient has used toothpaste on this brush to clean around these implants prior to using a mouth rinse, then here's what could happen. The products, as you know, the products of toothpaste, they dry up on these brushes and they stick to the contact point where the brush meets the bristle meets the core of the brush. Now, I'm making this point because there is a drug interaction between toothpaste ingredients and chlorhexidine, which decreases the activity of chlorhexidine. So therefore, it's a very simple message. If we're going to use these brushes to deliver a toothpaste and also to deliver a mouth rinse, and we're using chlorhexidine, which is the most effective mouth rinse, using chlorhexidine as our mouth rinse for our patient, we'd like them to use brushes dedicated to toothpaste and then a separate brush dedicated to the mouth rinse, so that the ingredients in the brush don't mix with those in the mouth rinse and decrease the activity due to that drug interaction. And by the way, a similar drug interaction occurs between stannous fluoride products and chlorhexidine. And so we'd like to also minimize that with the same procedure, separate brushes for the toothpaste with stannous fluoride in it, and separate brush for the mouth rinse containing chlorhexidine. And here's the two interactions I'd like you to remember listed for you. Number one, the activity of chlorhexidine is decreased by dentifrice ingredients. And number two, the activity is also decreased by stannous fluoride. Now here are the three major chlorhexidine mouth rinses on the market today across the world. We have PerioGuard, which has about 12% alcohol. I believe it's 11.5% alcohol. We have Peridex, which is also about 11.5% alcohol. Then we have PeroX, which is zero alcohol content. So now we have an opportunity to prescribe a product for our patient where alcohol is contraindicated. We have the opportunity to prescribe this kind of a mouth rinse for our patients. Now, what kind of patients are we talking about who should not have alcohol in their mouth rinse? Well, first of all, they're patients who maybe have been past alcoholics. They've broken the alcohol habit, and with these people, any amount of alcohol that goes into their mouth, whether they swallow it or not, can trigger the desire for more alcohol. So for alcoholics who have successfully broken the alcohol habit, we don't like to use alcohol-containing mouth rinses. Secondly, some patients take medications that if they swallow some of that mouth rinse, and by the way, when a person rinses with a product, they swallow about 15 to 20% of what they rinse with. Now that little bit that they swallow is enough. They're taking a drug like metronidazole to cause an adverse effect in the stomach, adverse gastrointestinal effect, causing gastrointestinal pain in our patients. So patients taking medications where alcohol is contraindicated, again for them, a product such as this one without alcohol is also of value. Now the third group of patients where we'd like to avoid alcohol are those with severe xerostomia. Because in severe xerostomia, alcohol irritates the mucosa. And these, of course, are many of our patients who are suffering with cancer and are undergoing cancer chemotherapy. And there are more and more patients across the world now being treated for cancer than ever before. So for these patients, again, we can recommend the alcohol-free mouth rinse. It will be not irritating, and it will definitely help minimize the mucositis that's associated with chemotherapy, as well as gingivitis associated with chemotherapy and peri-implant mucositis, which can also be associated with therapy, chemotherapy. So that's the story in terms of alcohol versus non-alcohol, and I'm happy that today we have these choices to give to our patients. Now the question also has come up, if you don't have alcohol in the mouth rinse, do you decrease the activity of the mouth rinse? Let's take a look at the data to see what the answer to that question is. Now here I've summarized the data from 3 different studies. One study, the 3 studies had 3 groups in them. There was alcohol-free chlorhexidine. There were 30 patients in that study. There were alcohol plus chlorhexidine, and there were 27 patients. And here is the control group. Now, if we look at the percent plaque reduction, what we see is here's the alcohol-free chlorhexidine, 38% reduction in plaque. Now, here the alcohol adds a little bit of a benefit to the plaque reduction, and you see a 61% reduction. But in terms of the control, of course, nothing's happening. But now, why do we want to reduce plaque? We'd like to reduce plaque in the case of gingivitis or peri-implant mucositis so that we can get healthier tissues. And we measure healthier tissues by seeing how much bleeding is occurring. So here's where we see that the alcohol-free chlorhexidine and the alcohol-containing chlorhexidine are very similar to each other in terms of their reduction in bleeding, which represents reduction in inflammation and therefore healthier gingival and healthy peri-implant tissues. So here we have a 56% reduction for the Pero-X, and for the chlorhexidine or the alcohol mouth rinses, Peridex and Perioguard, a 65% reduction. Difference is not significantly different. And here we see water had a little effect on reducing some of the bacteria on the surfaces, just the flushing action, and there's a 16% reduction. But statistically, of course, these numbers are significantly different from the control and same when they compared to each other. So this data tells us that yes, you can prescribe these products for your patients, the alcohol-free mouth rinses, with the same knowledge that you have of the effects of the alcohol-containing chlorhexidines. They will be as effective for improving gingival health. Now here are 3 studies that compared different mouth rinses with and without alcohol. And so I show them to you for your information. One, the Journal of Periodontology, which was published in 2002, was volume 73, page 317 to 321. Here is one, Journal of Clinical Perio, 2001, volume 28, page 168 to 174. And the third one is the Journal of Prosthetic Dentistry in 1998, and that was volume 80, page 685 to 690. And all these are studies carried on, or discussions of alcohol-free chlorhexidine. Now let's take a look at the literature out there in terms of what can we expect from chlorhexidine products that do contain alcohol. And you're going to see the results are very similar to those we saw for the Pero-X. For example, here let's take a look at chlorhexidine 0.12%, or in some of the studies they used the 0.2%. Here's a few examples of some of the names of the products, and you know, of course, what they are too. And here's the reduction. Now, this is looking across the world at different studies, giving you the averages. And the range in plaque reduction has been anywhere from 38% to 61%. Actually very similar to the Parallax in that 38% figure. Now, in terms of gingivitis reduction, again, compared to negative control, the range of reduction in gingivitis is 30.5% to 39%. Actually, the Parallax study showed a better effect than that, but I'm sure clinically the results will be very similar. Now, here's also taking a look at essential oils, which are also strong antiseptic mouth rinses. And here, the range of plaque reduction is 20.8 to 36.1% from across the world studies, and the gingivitis reduction, 27.7 to 35.9%. So this gives you a good idea of where a product like Parallax stands in terms of what the world literature shows us for products that contain alcohol in them, and how it stands in the same category as those products in terms of efficacy. Now, the basis for today's program is really evidence, and the basis for all the treatment we do on our patients must be based on evidence. So when you look at the evidence, you have to look at the literature, you have to look at the studies, and you have to see, were these good studies, and if so, yes, I will accept them, and I will accept this product as a recommended product for my patients. But I caution you, please be careful on what you interpret as evidence. Here I want to ask you, is this evidence? Is this positive proof of global warming? And of course not. You can see from the 18th century to 2006, is this why we say there's global warming? And of course, that's not the evidence we can accept. So let's make sure that when we accept evidence, it is valid evidence that we are looking at for our patients. Now, let's take a look at the progression of gingivitis. We know that initially, patients miss with their brushing and flossing, and more often on the lower than on the upper, and they get a slight gingivitis, as you see here. Then the more they miss, they start to get bleeding. And when they start to get bleeding, now they're worried about brushing and cleaning, so they don't clean as well because they don't want to get bleeding. That's in moderate gingivitis, and of course it's most advanced in the severe cases where they've now avoided these areas where they see bleeding, and now it even advances to the severe stage of gingivitis. So the important message we have to say to our patients is that when you're doing your mechanical methods of brushing, you have to be sure not to be afraid to cause some bleeding, because that's healthy bleeding, and after a few days of proper cleaning, the proper use of the mouth rinse I've recommended for you, that this bleeding will go away. And then they won't be afraid to carry out that bleeding. Now let's take a look. This is a picture of photomicrograph. Here's our tooth, here's calculus, and here's our gingival crevice. Now let's take a look here and see what happens. This is the area where plaque tends to form on the surface of our calculus initially, and of course out here supragingivally. But this plaque is the one that leads, it builds up supragingivally, slowly grows down and goes down into the crevice. And as it goes into the crevice, now you see the crevice, the gingival tissue, and the epithelium has micro ulcerations in it. This is what we have when we have a pocket forming around teeth. The gingiva on the surface is edematous, and the gingiva in the crevice is actually ulcerated. And the bacterial products can enter these ulcerated areas, and they can cause the inflammation to get worse. And if it's around implants, they cause the mucositis to get worse. They penetrate from these soft tissues into the underlying bone, which is down below in this area. And that's the progression that we're talking about in terms of the progression of gingivitis. So we have to be sure that the products our patients are using and the methods they use clean both supragingivally and subgingivally. Here are arrows showing you the supragingival area, and you see where this is the area where plaque begins to form. And then the plaque forming here actually has an effect on the plaque that forms subgingivally, and that's the plaque and its irritational effects from inflammation that causes the tissue to become ulcerated, opens up avenues of pathways of entrance of bacteria from the biofilm into the tissue, and from that tissue into the bloodstream, which of course leads to bacteremia, which we're going to discuss in the next section here. Now, what the American Heart Association said a few years ago, and most associations across the world repeated the same thing, they said that The maintenance, I'm going to read this with you because I think it's that important. The maintenance of optimal oral health and hygiene may reduce the incidence of bacteremia from daily activities and is more important than prophylactic antibiotics for a dental procedure to reduce the risk of infective endocarditis. In their discussion, they also went on to say, the more severe the gingivitis, the greater the bacteremia potential. So we have patients who are prone to bacteremia and who have had bacteremia before, bacteremia-related diseases. These patients in particular have to be taught to practice meticulous oral hygiene. And how are they going to do that? They're going to do that with proper use of mechanical methods, plus proper use of effective antiseptic mouth rinses as part of their daily oral hygiene regimen. Now, there was a study which was published back in 2010 by Dr. Daniel Fine in the US. And what he showed was that 2 weeks of rinsing with an antiseptic mouth rinse significantly reduced the bacteremia. And he actually took blood from the patient's brachial vein in the arm, and he measured the bacteria in that blood vessel. And this was in patients with gingivitis. And then he did another study, he repeated that study, so maybe that first study wasn't true. So later in 2010, he repeats that study, and that second study confirms the results of the previous study. And this data has been published in the Journal of Clinical Perio in 2010. So here's evidence that, yes, if we institute good oral hygiene, strict oral hygiene, including use of an antiseptic mouth rinse, we can significantly reduce the bacteremia in their patients, which in turn may lead to better general health of that patient. Now, where's another place where we'd like to be able to use a mouthwash, and what purpose could it serve? Well, we know that every time we activate a high-speed handpiece, or when we activate an ultrasonic cleaning device, that yes, we do remove the biofilm on the tooth surfaces. Yes, we can make a preparation on the tooth surface with a high-speed handpiece, but we're also producing an aerosol bacteria, an aerosol of bacteria, that goes out of the mouth and into the room air that we and our assistants and staff all breathe. So a very simple measure we can do, which is recommended by a number of dental associations, is including the American Dental Association, is pre-procedural rinsing. And if you're going to do pre-procedural rinsing, then do it with the most effective mouth rinses that you have. And of course, the gold standard for mouth rinses is chlorhexidine, as we all know, and that definitely can help reduce the aerosol. But let's take a look at the evidence, not just at what I'm telling you. Now, what does the evidence tell you? Well, let's take a look at the studies on reduction of bacteria in a back spray. And here, with this column will be the study that was done, and here it's going to show you the aerosol reduction for a mouth rinse compared to a water or placebo control. And these studies go back to 1964. Now, the first study, 1964 by Mohammed et al., shows using an antiseptic mouth rinse, 76% reduction in bacteria in the aerosol compared to 35% reduction with water, 2 to 1 in favor of the effective antiseptic. Litsky and Litsky, 1970. Chemotherapeutic mouth rinse, 89% reduction in the aerosol of the bacteria, 10% reduction with a control, which was water, colored flavored water. Rosen, 1983, again, chemotherapeutic mouth rinse, 73% reduction, water, control, 24%. Then 1992, Dr. Daniel Fine, he measures the reduction in the aerosol. He's the one that also did the bacteremia study. This was a different study in earlier times of aerosol reduction in the bacteria that we could breathe in. And here he compares this to a placebo control, and he finds that he compares a little differently than these people did. And what he's showing us is that there's a 93% reduction better than the control product. So all this data tells us, yes, pre-procedural rinsing with effective antiseptic mouth rinses will help reduce the aerosol in the bacteria that enter into our room. And we should use the mouth rinses which have been proven to have the highest efficacy against these bacteria in the biofilm. Now let's take a look at implants. And of course, this is a big area which has grown across the world. And we all would like the bone level to look very nice and high, as it shows here. But unfortunately, what we know does happen is this. Bone does, periimplant mucositis occurs followed by peri-implantitis, and we start to lose bone over time around these implants. So let's take a look at what the literature tells us we can do with mouth rinses as adjuncts to our therapy for prevention and also for treatment of peri-implant mucositis. First, let's look at some facts about implants. We know this. Following implant placement, and this little picture on the slide shows you this, bacteria begin to immediately colonize, and here they're colonizing in this picture within 12 hours. And then, this is 1 week later, this very complex microflora is established, very tenacious to the tooth surface. It's established within 1 week after the abutment connection. This is a critical time. During this time, from the placement of that implant to the placement of that abutment, it's important that the patients maintain those implants and adjacent teeth and surfaces which have very low biofilm scores. Why? The literature tells us healthy implants have a low biofilm score. Unhealthy implants have a very high biofilm score, such as we see here. Now, what we would like is for all our implant patients to look like this, where we have very, very clean surfaces. This is the photo I showed you earlier. This patient was using Proxa brushes and using them very effectively. One brush was dedicated to toothpaste, an antiseptic toothpaste, and the other brush was dedicated to chlorhexidine mouth rinse. And you see the nice clean surfaces that patient is able to maintain and the healthy peri-implant tissues that we see here. Now we also know this. There are some patients who need extra care, who need extra attention. These are the patients where we have to think, maybe this is the patient where I should recommend chemotherapeutic mouth rinse as part of their oral hygiene. Patients who we know from the literature, and it's published by people in Amsterdam in 2005, a past history of periodontitis represents a risk factor for peri-implantitis, and this is especially a concern in diabetics and smokers. And we know this. Although smoking is decreasing in many parts of the world, we still have heavy smokers in our practice. And number two, we do know that across the entire world, diabetes is on the increase, and so we have these patients more and more in our practice. Yes, we can place implants in these patients, but before we do that, we have to be sure that we have the maximum biofilm control that is absolutely possible in humans before we begin to place these implants. Notice what I said. Not after we place the implant, but beginning before we place the implant. We don't place implants in these people if they have teeth present until they can demonstrate to us that they can make these teeth relatively biofilm free before we place the implants. Now let's take a look at the literature. Back in 1997, we did a study and we looked at chlorhexidine and implants. We took patients in the study who had peri-implant mucositis, and we used chlorhexidine in the water pick with a small rubber pickpocket tip, which was directed subgingivally. And what we found was there was a significant reduction in peri-implant mucositis compared to the control group. We published this back with one of my graduate students, Dr. Philo, as far back as 1997, demonstrating a wonderful beneficial effect of chlorhexidine placed into a water pick. Now, let's take a look at another study. Here's a 6-month, our study was 3 months. Here's a 6-month study, and this is now using a dentifrice containing triclosan, and it's done in 60 patients. Now, in order to be in the study, here's the criteria. The patients had to have at least 2 implants with peri-implant mucositis. And actually, the average patients had 3.5 implants in the test group and 3.7 in the control group. They were told to brush twice daily with their control or test toothpaste. There was a test group and a control group. And then the evaluation was done on plaque, biofilm, bleeding on probing, and probing depths. And this again was published in the Journal of Clinical Dentistry, 2010. Here's the results. They found that plaque biofilm scores were equally reduced in the absence or presence of the mouth rinse, active or control mouth rinse. Now, the reason they thought this happened was that triclosan has, besides having antibacterial properties, also has some anti-inflammatory properties. And these anti-inflammatory properties may have contributed to the effect that we're going to see next, which is reduction in bleeding on probing, and this was reduced significantly better in the test group by 25% compared to the control group. So this was probably due not just to the antibacterial effect, but we saw that being equally shown in both groups, those manually brushing versus with the control toothpaste versus those brushing with the triclosan toothpaste. But when it came to looking at the gingivitis situation, the bleeding on probing was reduced far better in the test group than the control group. And that's a combination of the antibacterial effect of that agent, is my thought, as well as the anti-inflammatory effect. Then lastly, again, due to the antiseptic and anti-inflammatory effect, probing depth was significantly reduced in the test group, but not in the control group. Now, what we did note was that, the authors of the study noted, was that peri-implant mucositis took longer to resolve and does not resolve as well as gingivitis. It takes a little more effort for it to be resolved in these patients. A very important point to remember. Now, here's something else we have to think about. If we're going to use a strong antiseptic agent around our implants, do we have strong evidence to show that that implant surface will not be affected? Now, here we're looking at titanium implants, and of course they're blown up in these 4 pictures, very, very big so you can see. Now, this was a study done by Dr. Andriana, who's presented a webinar with this group before. He does a lot of work at our university on implants. And what he did was, he took a bunch of implants and he soaked them. They were titanium implants. And he soaks them, here's pre-treatment surface view. We're looking at with electron microscope. Then he soaks them for 1 week in Listerine. And as you look, you see no difference from here. Now 2 weeks soaking. Again, no difference from control. And 3 weeks of soaking. Again, no difference from control. So that data says, yes, it's safe to use a strong agent like Listerine around implants to help treat peri-implant mucositis. Now, the next thing he did was he took chlorhexidine, and he soaked these implants in chlorhexidine. And again, here's the surface of the implant before treatment. Here's the implant now soaked in chlorhexidine for 1 week. Again, no change from control. Here's 2 weeks, no change. 3 weeks, no change. Then the other group he looked at was Atriodox. And Atriodox he looked at because that contains doxycycline, which is used also in the local delivery system, which helps to control biofilm and kill bacteria subgingivally. And again, he looked at the implant surface. Here's the surface before. Here's 1 week after being soaked in Atriodox, doxycycline. Here's 2 weeks, and here's 3. And you see again, as before, nothing bad's happening. Well, this is the kind of data we have to have before we start putting things down around our implants. Because we want to be able to be sure that when we put things down around implants, what we're placing is not going to damage the implant surface. And if we have that data and that information, then yes, we can use various agents around these implants. What data I'm showing you is that doxycycline is safe, that and also minocycline will fall in the same category. Chlorhexidine is safe around implants, and Listerine is safe around implants. Now, he hasn't looked at other products, but there are other studies out there that do look at the effect of other products on implant surfaces, and it's important to be aware of that literature as you make recommendations for your patients. Now, there's one other mouth rinse I'd like to bring to your attention, and it's one which is also marketed by Sunstar, the gum brand of Sunstar, and that's called Rinsenol. And I want to bring this to your attention because not only do we have patients who have problems with plaque biofilm, but we also have patients who have problems with aphthous ulcers, with healing after periodontal surgery or implant surgery. And what this product does, it actually forms a soothing protective barrier on the surface of the implant and the adjacent tissue. And it has some anti-inflammatory properties. So between the protective effect and the anti-inflammatory properties, this product does help healing, wound healing, whether it be after a surgical procedure for periodontal disease or a surgical procedure for a peri-implant mucositis, or even following the placement of an implant, or be it for aphthous ulcers. So in other words, I'd like to recommend this product to you to try for your patients for its anti-inflammatory and protective effects. And here's an example of a patient with aphthous ulcers. They are not only on the buccal mucosa, but they also have on the tongue. They have multiple aphthous ulcers. Excuse me. And by the way, one thing we've noticed about aphthous ulcers from a study we recently completed was that patients who use large amounts, of ibuprofen, Aleve, any non-steroidal anti-inflammatory drugs, these people end up with aphthous ulcers more often than those who don't use the NSAIDs, non-steroidal anti-inflammatory drugs. So as an aside, for your patients who are having trouble with aphthous ulcers, you may want to recommend Rincenol to help these ulcers heal. But in addition, you may want to recommend to them stay away from analgesic products that fall in the category of non-steroidal anti-inflammatory drugs. And here's another patient with mucositis undergoing chemotherapy. Their mouth is very, very sore. These poor people are suffering from this mucositis. And again, the Rincenol would help to relieve this mucositis for the patient. As a matter of fact, not only Rincenol, but in addition, chlorhexidine helps relieve mucositis, such as we're showing in a case like this. Well, where are we today? Well, today where we are is at a point where we have patients in our practice, they all want white teeth and a better smile. But of course, we have to point out to them that in order to have the white teeth and better smile, they also have to maintain those teeth in a very healthy state, as this patient is showing. But even the animals, they would like to also have the same smile that our humans would like to have. So I hope today I've given you new dimensions in what we call personalized periodontal therapy. And we might say personalized periodontal / implant therapy. And I want you to remember that today's research is tomorrow's promise, because today's research is generating for us the evidence that we as clinicians need to select the best products that we can recommend to our patients for our patients today and tomorrow. Thank you very much, and now we have time for some questions. I'm looking at my questions, and I'll read the question to you. And let's see here. Here's a patient. She says, "What about Biotin? Is that as good to use?" Biotin is a product which has some ability, although the data is not real strong, has some ability to help people with xerostomia, but it does not have strong antibacterial activities or strong anti-inflammatory activities as we see with products like chlorhexidine. I have a question here. I have some difficulty getting pediatric adolescent patients to be compliant with chlorhexidine rinses. Any advice? My advice here is that you will have them compliant, particularly pediatric patients, if you use the alcohol-free product for them. And secondly, what I do in my practice is this, because some patients I would like them to be on for longer time periods on an antiseptic mouth rinse. We know that after about 3 to 4 weeks, we do get some stain from chlorhexidine. Of course, the stain can be removed by a simple prophylaxis, but patients, don't like to see that stain. So what I do is I will use, let's say after a periodontal surgical procedure or after a procedure where I'd like to have very good biofilm control, I will use chlorhexidine for 2 to 3 weeks. After about 3 weeks, we know that the stain will start to form. That's when I then switch to what I consider the next best antiseptic mouth rinse, and that's essential oil containing mouth rinses. And there are also alcohol-free versions of those available now, and that's where you may be able to find compliance and alternate, 2 to 3 weeks on the chlorhexidine, and then 2 to 3 weeks on the non-chlorhexidine product, and then go back on it. And that way you can minimize the staining, but yet get the good efficacy that we can see from chlorhexidine. Here's another question which I think is very important. When is the best time for patients to rinse with chlorhexidine, since toothpaste can inactivate it? I recommend them to rinse after meals, not after brushing. I think that's a very good suggestion after meals, Now, some patients say, well, I don't like to rinse after meals. I would like to keep the taste of the food I've eaten in my mouth for a while. And so for that kind of patient, you can say, brush your teeth in the morning like you always do. Then do a vigorous water rinse. And then wait, before you do the water rinse, wait about 5 minutes for the uptake of the chlorhexidine into the biofilm. Then you do the vigorous water rinse. And then there won't be residual toothpaste in the mouth. And then they can go ahead and use their chlorhexidine, and you won't have to worry about a significant drug interaction occurring. Let's see here. And my question is, what is your opinion about using Listerine as a pre-procedural rinse? Listerine is the study I showed you in one of my slides was by Dr. Daniel Fine, and it showed that the Listerine, when compared to the control, the reduction in the back spray was approximately 93%. So Listerine is effective as a pre-procedural rinse, and chlorhexidine is just as effective as a pre-procedural rinse. And here's another question. What about the use of a fluoride rinse to reduce bacteria? Unfortunately, fluoride rinses are not good for reducing, killing bacteria. One exception is the standard fluoride rinses, and they have some benefit in reducing bacteria, killing bacteria. But in general, fluoride rinses their best purpose is to deliver fluoride to the tooth surfaces. They have a minimal antibacterial activity. I'm just scrolling down the questions here, looking at them, trying to talk with different people. Here's one, let's see. Oh, this was the one, this is a question. What do you do for patients who are using chlorhexidine and are having issues with staining? That's where I said use the alternating rinses that I mentioned. For 2 to 3 weeks, use the chlorhexidine. Then for 2 to 3 weeks, use the next best product, which is Listerine. And then again, go on and off with the 2 rinses. That works very well in my practice, and we get minimal chlorhexidine staining. Now, this is another important point I just thought about. If someone brings you a mouth rinse and they said, this mouth rinse has ingredients in it, it's chlorhexidine, there's other ingredients that will cause it not to stain, that is not true. If the mouth rinse does not cause any kind of staining and has ingredients in it to decrease the staining, those products tend to be not as effective as the chlorhexidine without those so-called clarifying ingredients in them. If you don't have stain, it means the product is not killing bacteria to any significant level. Here, I'm just scrolling down my list, so bear with me for a few minutes as I try to find some different questions. Well, here's a question about Rintanol. Is Rintanol over the counter or by prescription? Rintanol is over the counter, so that's what's another nice thing about it. The patient just can go into a drugstore and they can just purchase it. And you'll be very, very surprised at how nice the tissues around implants will look with it if there's any kind of inflammation going on. And also if they have aphthous ulcers in their mouth or mucositis, the relief that it gives them is very good. As I also mentioned in my presentation, we can get some mucositis reduction from the chlorhexidine, but of course we wouldn't use the chlorhexidine with alcohol. If they have mucositis, it would be irritating, so we would use the alcohol-free chlorhexidine for those patients. Here's another staining question, which we already answered. And let's see, I'm just trying to find something different here. Here's a good question. Are there any other side effects to long-time use of chlorhexidine products aside from staining? Actually, there really aren't. As a matter of fact, there is one study which was done. It was a 2-year study. It was done on soldiers in the Danish army. And of course, they could tell those soldiers you have to use the product chlorhexidine rinse twice a day, and the soldiers got a lot of stain, of course, in their teeth, and they did clean their teeth once in a while to reduce some of the stain. But it was a 2-year study. There were no significant adverse effects that occurred, and also there was minimal occurrence of a resistance of bacteria that developed. So that study, in the 2-year study in the Danish soldiers, showed that the chlorhexidine was safe for up to 2 years of usage on a daily basis, and in addition, that the staining was objected to by the people, but it was removed with polishing, so they were agreed to stay in the study. And there was also minimal development of resistance because they took bacterial flora samples, and resistance did not occur with use of chlorhexidine. Let's see here. Some of these questions are repetitious, so I have to sort of go over them. Oh, is there a risk of resistance with long-term use of chlorhexidine? No, as I said, the study that I quoted, the Danish Army recruits, that was up to 2 years of use, and no resistance did occur. Here's one. Toothpaste containing stannous fluoride stays in plaque for a few hours, so why use the mouth rinse? Unfortunately, the stannous fluoride toothpaste, their primary mode of action is delivering fluoride to the tooth surfaces for their anti-caries effect, and their secondary action is to also kill the bacteria in the biofilm. They do not do this as effectively as does chlorhexidine. So that's why the chlorhexidine would be used with a patient who uses the stannous fluoride. But in this case, what we suggest is that for people who are using stannous fluoride dentifrices, my recommendation is that they wait at least an hour before they use their mouth rinse product. Because after an hour, the stannous fluoride is dissipating out of the biofilm. The chlorhexidine can then enter into that biofilm and attack the bacteria. Here's another question about risk of resistance long-term chlorhexidine. Of course, we addressed that already. Let's see here. Here's an interesting question. What is your take on coconut oil for rinses or patients that want to use that product? The use of coconut oil as a rinse is part of a concept called oil pulling. Oil pulling has no strong studies behind it. As a matter of fact, when I lecture to my students, I discussed the fact that manufacturers even say in their ads for oil pulling that we are collecting research data at this point in time, and we want you to be part of our research study. Therefore, please write in and tell us about your experiences with coconut oil. Now, coconut oil does have some antibacterial activities, but unfortunately, there are no controlled studies to show benefits of coconut oil rinses or the concept of oil pulling. As a matter of fact, with oil pulling, patients are told to keep the product in their mouth for about 20 minutes, and that it will not only help their gingival oral health, but also will help their systemic health. I have to say, that is not evidence. That falls on the clothesline picture that I showed you with the swimming suits. Okay, I think we have time for maybe 1 or 2 more questions. Let's see here. Do you recommend patients always use a mouth rinse or only during a disease state? That's a very good question. Now, what I do recommend is this. Of course, if I have gingivitis or a patient who has recurring gingivitis, or I know that there are patients that come into my practice and they always have some gingivitis, I like them to use a chemotherapeutic mouth rinse. And what I do is I have them use it for at least 3 months. When they come back on a recall, I then say, now you know what a clean mouth feels like. Now for the next 3 months, if they're on a 3-month recall, I'd like you to use your toothbrush and your dental cleaning devices, and don't use your mouth rinse, since your mouth is quite healthy now. And let's see how you do in the next 3 months. If they come back and they're doing well in the next 3 months, then no, they don't have to have the mouth rinse. However, if I see the disease coming back, be it gingivitis or peri-implant mucositis, then I put them back on the mouth rinse. And this is how they sort of teach themselves the benefits, and they believe the things you've told them when you follow that kind of regimen. At least it works very well in my practice. Okay, I think we're just about, I might have time for one more question. We're almost out of time. Oh, here's a question. What is Corsadil? Corsadil is sold in other countries outside the U.S. It's another form of chlorhexidine. It's chlorhexidine with alcohol in it, and that has been included in some European studies, where they do studies on the efficacy of alcohol containing chlorhexidine. Here's a question about some little different question. How do you feel about antioxidant rinses such as the one offered by Perio Sciences? Unfortunately, I haven't seen the data from Perio Sciences, nor have I seen any studies on the use of antioxidant rinses. There are a few, let's say, any studies that I feel are proving efficacy on the use of antioxidant rinses. As far as products from Perio Sciences, I don't know what their products are. Okay, well, I think we're out of time. I hope you've enjoyed today's presentation, and thank you for your attention. Thank you for your questions, and have a nice day or evening wherever you are while listening to this program. Thank you very much.